When a patient with suspected severe infection arrives in the ICU, should you start with a broad spectrum or a narrow spectrum? The correct strategy that we follow is that start broad, then narrow it down as early as possible. Why we should start broad spectrum initially? Because in sepsis and severe infection, the pathogen is often unknown at presentation. So early broad spectrum therapy ensures the coverage for gram-positive, negative, and resistant pathogens when risk factors coexist. This reduces the risk of missing up a positive organism in the early critical phase. Examples include combinations like piperazine, tazobactam, carbapenems, vancomycin when MRSA risk is there. The big mistake we make is that we start broad and keep it broad and never narrow. Broad spectrum antibiotics continued unnecessarily leads on to antimicrobial resistance, secondary infections, and Clostridium difficile colitis, and occasionally drug toxicity as well. So after 48 to 72 hours, review your antibiotic. New data becomes available, the culture results, sensitivity reports, clinical response, and imaging findings. At this point, we should reassess aggressively and think of de-escalation. What de-escalation means is that it involves switching to a narrow spectrum antibiotic, stopping unnecessary agents, and targeting the specific pathogen identified. For example, we may start with piperazine, tazobactam plus vancomycin, and culture shows E. coli sensitivity to ceftriaxone. Switch to ceftriaxone alone unless you are suspecting ESBL. So the modern antibiotic strategy is start broad spectrum when necessary, but narrow it at the earliest as soon as possible. Because good antimicrobial stewardship means the right drug for the right bug for the shortest duration possible.